Good morning, ladies and gentlemen, colleagues and friends. First, I want to really sincerely apologize for not being able to be here with you personally today, and I want to thank the organizers for allowing me to give you this lecture via video. When I first accepted the honor and the responsibility of doing this opening lecture, the Zika crisis, and it really is a crisis right now, was not on anyone's radar screen. It was completely unanticipated, but over the past couple of months, this has really consumed us, me particularly in my involvement in the policy and response to this. And so I really apologize for not being able to be there. Monday morning right now, I'm going to be dealing with the National Security Council about how we're going to respond in the event of seeing this on the southeastern coast and the Gulf Coast area, which is very much is threatened by what might happen over the summer. So again, I really apologize. But let's just get on with the lecture then. Thank you very much. So as you can see from this slide, the title of my talk is HIV/AIDS, Ending the Pandemic and Follow the Science. And I hope over the next several minutes you'll appreciate why I chose this particular title. I've divided my talk into three major components. I want to talk a very little bit about the reason why I have optimism in 2016, given our current treatment and prevention capabilities, that we will be able to turn around the trajectory of this pandemic, even in the absence of the still major remaining challenges that we have scientifically. And we can implement that. However, I want to focus most of the talk on what these challenges are. And as you can see, the two here are addressing the HIV persistence and the challenge of developing an HIV vaccine, the subjects of this particular symposium. Starting off first with the reasons for optimism, just a very quick background. Most of you are familiar with these numbers. For those of you who are not, there are 37 million people living with HIV in the last recorded year, which is 2014, 1.2 million AIDS deaths, 2 million new HIV infections. That is globally. In the United States, although we have become somewhat complacent, as you can see from these numbers, there's nothing to be complacent about. 1.2 million people living with HIV, more than 670,000 people have died. A very embarrassing statistic that there are 40 to 50,000 newly diagnosed HIV infections, and this has been this way for the last 15 years. Among those, there's a greatest burden is being suffered predominantly by African American men who have sex with men, particularly young individuals, where more than 20% of the new infections are in individuals 13 to 24 years of age. Talking about the science that has been accomplished over the last 35 years is really nothing short of breathtaking. I could spend the entire time on each of the areas pointed out on these bullets, but the one that stands out to be the most transforming are the advances in the area of treatment. If you look now over the years and gradually from the first approved drug in 1987, AZT or zidovudine, which I'll get back to in a moment, we now have in our armamentarium more than 30 drugs, when used in combinations, have completely transformed the lives of HIV-infected individuals. When I first started seeing and taking care of AIDS patients in the fall of 1981, the prognosis of those individuals with no treatment at all was anywhere from a life expectancy of 1 year to a year and a half, a dreadful situation. This is a situation which has been completely transformed because now with the drugs that are available, we can now show that individuals, for example, a person coming into my clinic today or tomorrow, and the last person I saw was just this past Friday, was diagnosed with HIV at an early age, put on therapy. If they take their medications, you could predict that they will live an additional 50 years. This is not confined only to the developed world, because with PEPFAR and the Global Fund and other organizations, we now have 16 million people receiving antiretroviral therapy, which has averted over 8 million deaths since the year 2000. Combination HIV preventions has evolved together with therapy. Early on in the epidemic, we had low-tech ways of preventing HIV infection with education and behavioral modification, the use of condoms, clean syringes. But now over the years, with the interdigitation of treatment modalities into prevention, we now have a very powerful prevention capability. Shown on this slide is the four major areas in which treatment overlaps with prevention. It started off with post-exposure prophylaxis, the very, very important studies of the prevention of mother-to-child transmission, the transforming studies on treatment as prevention, and now the use of pre-exposure prophylaxis, which is having a major impact on preventing infection in high-risk individuals. All of this has led, as shown on this slide, to a dramatic decrease, a decline both in deaths and in new infections, with a trajectory that is going in the right direction. All of this has prompted me, just a couple of months ago, at the invitation of the Washington Post, as a matter of fact, to write an editorial talking about the fact that there are really no more excuses. We need to implement the scientific tools that we've developed over the last 35 years, and we can end the epidemic as we know it now. Not end it completely with no new infections, but certainly turn the trajectory around. Now, having said that, we still do have important scientific challenges, and that is the subject of this meeting. Two of the most important are the persistence of HIV and the road towards an HIV vaccine. So let's start talking about that. I can't be giving every detail of every paper that was ever published. However, I want to talk about a 40,000-foot look at the directions we're going. Let's take a look first at addressing HIV persistence. A couple of years ago, this slide, which I would have shown often, the title with the slide was an HIV cure. We're thinking a little bit different about that now because it's really the question of persistence, which can be divided into two areas. A true classic cure, which would be eradicating the very last of the virus in the reservoir, a very, very difficult task to be sure. And the other is not necessarily eradicating the virus, but controlling the viral rebound of what we're now calling sustained virological remission. So let's take a look first at the eradication of the reservoir and the attempts towards that goal. The potential strategies are listed on this slide, and there have been many of them. Again, I can't mention each and every one, but I want to just take a look at the landscape. The first one being latency reversing agents to deplete HIV reservoir. 2 decades ago and more, we did the first attempt at this with giving a very powerful immune activator, interleukin-2, to see if we could essentially flush out the reservoir while people were receiving antiretroviral therapy. We thought we did very well when we were looking at the data in that we couldn't find viable virus in the blood, in the lymph node, in the gut. And yet when we discontinued therapy, there was inevitable rebound in essentially everybody. The list you see on the slide are a variety of approaches that have actually been performed. Again, the results thus far have been unsuccessful in the end game, but may be steps towards something that will eventuate into success. I wanted to point out that last bullet, the toll-like receptor 7 agonist, and just point out one among many studies, an interesting study that was presented at the CROI meeting just a month or so ago, in which experimental TLR7 agonists suppressed in a non-human primate model after interruption for a prolonged period of time, which has now led to the initiation of a phase 1b clinical trial to try and mimic that in the human model. Again, one of a number of approaches. Immunotoxic therapy directed at the reservoir, something we've borrowed from the field of cancer. These are studies that date back to work that Ira Pastner did at the NIH, now together with Ed Berger, the most recent of which are just a couple of examples shown on this slide. The bispecific T-cell engager, or BiTE, the dual affinity retargeting protein, or DARTs. These are platforms which are now being done in clinical trials in cancer. The question is, can we successfully borrow that and apply it to HIV-1? Right now, these are 3 of the studies that are going towards a proof of concept, although there are little or no in vivo data yet. This is something that is going in the direction to see if we can apply that extraordinary technology to the HIV field. The issue of stem cell transplantation I could spend the entire time on, because it really started with an unusual situation that we're all very familiar with, the Berlin patient Timothy Brown, who actually had the situation of having an acute myeloid leukemia, which was treated with chemotherapy and an aggressive approach, but the transplant of the stem cell was with a Delta 32, and after a very long course, it is now very clear that Tim is free of virus. So theoretically and practically, not just theoretically, but practically, this is a cure. How can we apply that in the concept to doing it in a way that's more practical? There have been a number of attempts, some unsuccessful, to replicate that, others that are still trying while patients are on antiretroviral therapy. But what this has done has opened up the field of, can we then, with gene therapy or gene editing, do the same thing that was done with the stem cell transfusion and transplantation? And this is a study that Carl June, whose primary interest had been in the arena of cancer, is shown in doing a gene editing of CCR5 in autologous T cells of a person infected with HIV. And the results, when you look at them, seem to get better and better for the duration and prolongation of the lack of rebound. In fact, as most recently as the CROI meeting, a paper from Rafiq Saikali and his colleagues showed the control of viremia during treatment interruption for a period of time that, as shown on this second bullet, from 14 to 26 months after analytical treatment introduction, with the viral measurements still really quite low. So that's a field that's moving along. Now, given the promise of the use of CRISPR-Cas9 in a much more sophisticated gene editing technology and capability, I believe that this field will be moving more rapidly in the right direction. So we need to keep an eye on that. Now let's get to the issue of something that might be, and I'm not sure, more practical in the sense of easier to do, and that is controlling viral rebound, or what we call sustained virologic remission. So on this slide, the first element of the slide has something that many of us have been talking about for some time, that what you need to do right off is put yourself in a favorable position, namely early suppression of HIV viremia with antiretrovirals for two reasons. One, minimize the size of the reservoir, and two, allow for the preservation or lack of destruction of the immune capability by chronic viremia over years. If you do that, there are three pathways to being able to control virus that has not been eradicated, but that you can control immunologically, leading to the discontinuation of ART and sustained control of viremia. The first is natural HIV-specific immunity. In other words, if you treat someone early enough for a while and then stop therapy, will their natural HIV-specific immunity actually prevent rebound? We have found this to not be the case. This is one of the earliest studies that we did 17 years ago, in which we treated patients for several years and then empirically stopped therapy. And as you can see on the right panel, essentially every one of them rebound right to the area which was their original viral set point that usually occurred in 14 to 21 days, 2 to 3 weeks. The other is therapeutic vaccination. There have been a number of attempts. We have a study right now. I would love to be showing it to you, but it's a double-blind, placebo-controlled trial, and hopefully at a future meeting I'll be able to share that data. The reason I can't share it with you now because I don't know who got what, because it's still double-blind, placebo-controlled trial. And the other one is something that I want to just spend some time on, and that's the passive transfer of HIV-specific antibodies, particularly those that have been characterized as broadly neutralizing. Now, this is a slide of the HIV trimer that I'm sure is familiar with individuals in this audience. And what it shows is the name of some, not all, of the described broadly reactive neutralizing antibodies binding to various epitopes on the HIV envelope primer, such as the CD4 binding site, the glycan super site, et cetera, et cetera. Now, when you look at these antibodies, the question is, can we passively transfer them in order to show that they actually have antiviral activity, both in and of themselves, but also as concept provers for vaccine development? So let's take a look at the potential applications of these broadly neutralizing antibodies in three separate areas. The first is the area of actually preventing HIV infection in an uninfected individual. I don't have time to go into that because I want to focus on the other areas, but John Mascola at the CROI meeting in February gave a beautiful lecture on harnessing antibodies for HIV-1 prevention and treatment. And if you have the time, if you haven't seen it, go online and take a look at that. That really is a very fine lecture. And you'll probably be hearing from John talking a bit more about this later on in the meeting. If you look at the treatment with potential application of an antibody, that is together with long-acting antiretroviral drugs. In other words, instead of taking only an antiretroviral drug every day, can you have long-acting antivirals and antibodies together to allow one to draw out the intervention as opposed to every day? And in fact, there's a protocol in development, ACTG 5357, which is a proof of concept of a study of long-acting cabotegravir, which is an integrase inhibitor, together with long-acting VRC to ask that question, can you maintain viral suppression in HIV-infected adults whose virus had been previously suppressed with conventional ART? Can you switch over to this? And the protocol shares are shown on the last bullet in this slide. Now let's go to the issue of the control of viral rebound following the discontinuation of ARVs. Getting back to this slide now, which shows many of these antibodies, 2 of them have been in trials that have actually been reported, VRC01 and 3BNC117, and another one, Michelle Nutzenzweig, is actually in the preliminary phases of looking at that in a human of 10-1074. Let's take a look at this. The studies that are done in humans first need to show that they can actually block virus. This is an interesting paper that Nutzenzweig published in June of 2015, showing that you can actually have more than a 2-log drop in people with ongoing viremia by infusion of the antibody 3BNC117. Together with the group at the VRC, namely John Mascola and Julie Ledgerwood and Barney Graham and others, Rebecca Lynch, we took the antibodies, namely VRC01, and asked the same question. Can you, in fact, drop viremia in someone with active viremia? And on the A panel on this slide, you see if the virus is actually very low in that yellowish looking one, you can get a prolonged suppression with a single infusion. If you go down to B and look at them all together, you see acutely, and then in C it blows it up. You have an almost invariable diminution of viremia, which then ultimately rebounds, likely as the antibody pharmacokinetics wear out towards the end of that study. So based on these studies, there are 3, to my knowledge, and I think there are only 3, ongoing studies using broadly neutralizing antibodies in the context of analytical treatment interruption. The first is Michelle Nutzenzweig, who's doing 3BNC117 and also starting on 10-1074, and then there are 2 with VRC01, one in Pablo Tebas's laboratory and one in my laboratory at the NIH. So what I'd like to do now is summarize some of the data associated with the study that we're doing. This is an exploratory, open-label study of VRC01 in subjects with chronic HIV infection who undergo analytical treatment interruption. My collaborators and co-workers on this are shown, the people in my own lab, the LIR, led by Taeyuk Chung and Mike Snella, Susan Moya, and Kat Claridge, and our Vaccine Research Center, or VRC colleagues, as well as our clinical staff. The study population were 30 HIV-infected individuals who initiated ART during the chronic phase of HIV infection. So these were not people who were acutely infected and treated, which is important because there may be a difference in the duration of suppression, if there is any, in different populations. They had to have had suppressed plasma viremia for more than 3 years. The CD4 count had to be greater than 450, and there were 10 patients are currently enrolled. Now, importantly, in any clinical study, for those of you who have not done them, are very strict criteria because you don't want to harm the patient, obviously, to get interesting data, is when do you stop the VRC01 and restart ART? And the criteria are shown in this slide. A confirmed more than 30% decline in baseline CD4 count, or an absolute CD4 count of less than 350, a sustained, namely about 4 weeks or more, of an HIV RNA level of greater than 1,000 copies, or even an incremental increase that doesn't necessarily go over 1,000, but that's greater than 500 at 3 consecutive visits. So it was very strict looking at safety for the patient and any HIV-related symptoms or pregnancy. The study design is shown on this slide. All of the study participants received infusion of 40 mg per kg of 3 days prior to and 28 days following treatment interruption, receiving the VRC01, and then monthly thereafter. If you look at the bottom of the slide with the yellow bar, you see that delineated there. Plasma viremia was measured at the time shown on the slide, and the blue arrows indicate VRC, the red, the stop ART. And here are the data. And it's very interesting because when you look at data like this, you get an appreciation of a few things. One, they all rebound for sure, but when do they rebound? And the question is, since this is a essentially phase 1 study, proof of concept, as you can see, the yellow arrowheads are the VRC infusion. The blue asterisks are when, according to protocol, we started therapy again, or even under other circumstances. Now, I'm going to talk to you about the median or mean duration of suppression and how that relates to prior experience. As I said, it's about 14 to 21 days. With better antiretroviral, it probably would be more. So looking at these, really every one of them rebound. Look at the third one over on the top panel, VO3NP. That's interesting because that's somebody that would not have been put back on by us, but he decided, he got nervous, and he wanted to go back on therapy. VO4EB is an interesting patient. He went up and then came down spontaneously with interest, all of us. However, as we do with all the patients, and it tells you a little bit about clinical research, we drew a plasma level of ART and we found that that person, without telling us, had gone back on antiretroviral therapy. For those of you who are doing these kinds of studies, it's very important to check whether the person is going back on therapy. But having said that, there's a great deal of variability. Look at VO7RD, just rebounded almost immediately after the interruption of ART. And yet VOADA went on for 7 weeks, much longer than we would usually see. The other issue is that we did not pre-screen for resistance or sensitivity to VRC01. We took on all comers. Now these two slides here, this is interesting because I want you to look at V10HB. As you can see, that person had gone out to 91 days, which was really quite long, and that could have been, under certain circumstances, if we stopped the study then, say, well, that was really a success. Except when you follow them longer, this is what happened, and the patient rebound. At the end of the day, I think not unexpectedly, because this is a single antibody given to people that was not pre-screened, that what you had was a median duration of virological suppression around 39 days, which according to some historical controls is actually an increase in the time frame of rebound. But again, that's not really the reason for the study. The study is to see if you can do it safely and get the right kind of kinetics with a single antibody. So questions arise. Did they rebound because the pharmacokinetics was such that there was no more antibody around? Not so. In the blue are the level of the plasma concentration of VRC01, the dotted line being the level that you would expect would suppress in vitro. And at every time there was a rebound, as shown in red, the level of VRC01 in the plasma was adequate to suppress. So it wasn't the level of VRC01 in the plasma. Now this is, I believe, very interesting, because what we did is that we didn't pre-screen, but after we took the viruses that we'd isolated and took a look at their sensitivity or not. So what we have are a number of infectious HIV isolates, and now we're looking at the sensitivity or suppression over control of VRC01 in blue compared to others like 3BNC117, 101074, PGT121, and UB421. This individual, unbeknownst to us until after, actually had a resistant virus right before we even started the study. So pre-infusion, he was resistant to VRC01, but was actually sensitive to 3BNC117. Not surprising that that person rebounded. But this is what we see in other patients. Sensitive to everything pre-infusion, as shown on the top panel, but if you go to the bottom panel, post-infusion had developed resistance both to VRC01 and 3BNC117. So there's a lot of issues that are involved. One, pre-existing resistance, and two, the selective selection of resistance, what we actually see here, which is very interesting because individuals who had had virus going around for years very likely were immunologically selecting for resistance all along, which is one of the things that's different that when you get a patient that you're going to treat with an antiretroviral who comes in fundamentally with a sensitive virus and doesn't have drug-induced selection prior to the time that you start, even though someone might obviously get infected with a virus that was resistant in another individual. But the summary from this, having said that, is that while multiple transfusions of VRC01 was safe and well tolerated, the majority of the patients experienced plasma rebound despite adequate levels of antibody. There was pre-existing and or rapid emergence of resistance contributed to the plasma rebound, and future strategies involving passive transfer may require a bunch of things, combination of antibodies or resistance pre-screening or other issues. These are some of the ways that one can improve results with broadly neutralizing antibody in the context of these types of studies. They're shown here: more potent antibodies, combinations, extend the half-life, vector-based antibody production. I want to concentrate just on one of them, combinations of antibodies, because I want to make it analogous to what we've done using antiretrovirals. This is a study that was published by Muscola and his colleagues in March of 2015, and that is that the combination of two broadly neutralizing antibodies, and we have a much, much greater menu of them right now, gave over 98% coverage. So if you mix and match the antibodies for potency and percentage of resistance, you might get the right combination. So let's show and see how we can harken this back to antiretroviral and say, although this was not a success, it's the beginning of a long journey. Some of you may not remember the fact that back in 1987, when we had the first breakthrough with AZT, it was a study done in '86, showing that there was 1 death with AZT and 19 deaths with placebo. It was the first and last placebo-controlled trial of antiretrovirals in HIV-infected individuals. There was a lot of happiness and joy about these results, but we all knew deep down that this likely would not last, and this was proven by Doug Richman just a couple of years later, the obvious and inevitable emergence of resistance, which we saw here. Now, this is a timetable of the development of drugs. Look at that on the left-hand side. When we had Zidovudine in 1986, approved in 1987, it was till 4 years later that we had the second drug. We don't have that situation right now with the antibodies because we already have a number of antibodies that we can go right into combination therapy. And this is what we hope happens, because this is the story with ARV. In 1987, with monotherapy, we had a little drop in viremia and then rebound back. A couple of years later, 5 years later, 6 years later, when 2-drug therapy came in, a more profound drop and a little bit slower in rebounding. And then in 1996, the 3-drug combinations which we're using today, profound diminution to undetectable, and then followed by duration of suppression. That's where we hope we will be with these antibodies. Let me move on now to the last part, and that is the challenge of developing an HIV vaccine. As I've spoken to you in this group and other groups in the past, there are 2 major approaches to vaccinology, what I call empirical or inductive, or theoretical or deductive. In the empirical approach is what vaccinology has been doing for decades and decades. You mimic the infection, you are not necessarily sure what it was that protected, but you mimic the infection, you get a modestly or hopefully very effective vaccine. If not, you improve on it. you do an empirical trial of something that looks like the microbe in question. Theoretical or deductive is that you don't have a model for protection, so you want to look at some inkling of what would point you. So you look at the optimal correlate of protection and you design an immunogen to induce that immune correlate. With regard to the first one, the empiric or the inductive approach, we've done that multiple times over the years, dating back as early as 1987 when the first trial was done with an envelope protein. All of those have failed except one has shown an inkling of success, modest 31%, not ready for prime time, but it was an important study, the now very well recognized RV144 of 16,000 individuals in Thailand, which showed a 31% efficacy. But that is what empiric trials are about, because you use that to try and find immune correlates as shown on this slide. They were somewhat surprising. We were looking for neutralizing antibodies, we were looking for CTL responses. And what we found were IgG antibodies against the V1, V2 region, which one would not have predicted would have been the region that it was directed against, and this was associated with reduced infection. These were non-neutralizing antibodies that were mediating ADCC, and there was an interesting reverse correlation with the presence of IgA antibodies against the same epitope. So what's going on right now in studies that are already beginning in Africa and other areas and other regions is to try and improve and amplify an RV144, increase the strength, the breadth, and the durability with multiple boost, modified vectors, and adjuvants. So let's go on now with the last one, the theoretical or deductive approach. What do we mean by that? We know that broadly neutralizing antibodies, and this is now well known, well studied, and well spoken about, that it occurs in a relatively small percentage of individuals, about 20%. It takes quite a long time, measured in years, for that to occur. But we do know that the gold standard of what we would hope, and we're trying to prove that with the passive transfers, is that neutralizing antibody might be protective. Now, the trouble is we have an issue with the induction of that in the natural way, namely natural infection. They also have other issues, high degree of somatic mutation, unusual traits such as autoreactivity. It has been focused on now by a number of elegant studies, many of which you're going to hear about at this meeting, taking a look at the HIV envelope trimer. Now, the trimer, as I showed before in the others, have neutralizing epitopes that have been defined by the broadly neutralizing antibodies derived from people who were naturally HIV infected. The challenge, the fundamental challenge now, is to take those neutralizing epitopes in a certain form, in a certain conformation, turn them into an immunogen to ultimately induce broadly neutralizing antibodies. Two factors prevail in that and have dominated the field. The issue of the stability of the envelope, the trimer, and proper engagement of germline B cells and sequential engagement of the B cell lineage. Regarding the stability of the HIV envelope, with elegant technologies, we've been able to take a look at this, and now we feel that we have a better understanding about what might be needed. First, let's take a look at the importance of the stability. The HIV envelope is naturally unstable. The envelope changes conformation upon binding to CD4, in particular exposing immunodominant V3 loops, among other things. That has limited neutralizing activity. Stable trimeric envelopes preferentially bind these neutralizing antibodies that we're interested in. So one can make a reasonable assumption, it may not turn out to be that way, but a reasonable assumption that stable trimeric envelope would serve as the preferred immunogen to induce broadly neutralizing antibodies. And a number of elegant studies from a number of labs shown on this slide, and even others who are doing work in this area using crystallographic capabilities, cryo-EM, are getting down to the stability of the envelope trimer. Others have tried to engage germline B cells in different models with some degree of success, which I'm sure are going to be more successful as we go on. You'll probably be hearing more about that at this meeting. Once you do that, once you engage, you have to have what we're calling, what we believe, is sequential engagement of the B cell lineage. Bart Haynes, in a study a few years ago, had the opportunity, as it were, to show that if you get someone early enough and follow the coevolution of the virus and the antibody in an HIV-infected individual, where the virus enters, you have an immune response, it selects mutation of the virus, selects another immune response, and on, back and forth, until you get a broadly neutralizing antibody. That has been done at a much more sophisticated level, and you're going to be hearing about this, I'm sure, later on in the meeting, in a recent study, again from Bart's group, in which they looked at that same coevolution, but now bringing into the picture a cooperating lineage that actually has the ultimate goal and ultimate actually accomplishment of a mature neutralizer. Will this be able to be induced in vivo in an individual that we want to deliberately do this? I look upon this, and someone had mentioned, I think it was Peter Kwan was talking to me one time about this dance between the HIV antibodies, and in my mind it looks like almost this complex kabuki dance between the HIV envelope and the antibodies on the maturation pathway from germline to broadly neutralizing antibodies. This was actually schematically diagrammed by Michel Nutzenzweig in a paper some time ago, in which he diagrammed what we're hoping to do. Hopefully engaging germline, but even if not, to essentially, in an iterative way with sequential immunogens, get to the endpoint of neutralization. This leaves us with current major challenges for antibody-based HIV vaccine. We may not get to that end game goal. I think we will, I hope we will, but the challenges are clear, and they're shown on this slide. First, the envelope trimers. Can the early strain-specific neutralization that has been seen in some studies be broadened? What about germline induction? Can this actually be achieved in humans? It certainly looks difficult. Lineage-based vaccine design. Can sequential immunogens guide the immune response? What about affinity maturation? Can we attain sufficient somatic hypermutation with standard vaccine regimens? We hope so. And what about the issue of tolerance? Can clonal deletion that impedes induction of broadly neutralizing antibodies be obviated? We don't know, but we're certainly going to try. We as a field, that I mean. Now, having said all that, what are we looking for? Well, we're certainly almost going to have T-cell approaches towards an HIV vaccine, both for the standard classical T-cell help, as well as for things like cytolytic T-cells from the studies, the very interesting studies of Lou Picker and the colleagues. So although I've been talking about antibody all along, we should not rule out the possibility that there will be a significant contribution from T-cells. So what about this slide? RV144 on the left, 31%. Obviously, in my role as the director of NIAID, I get involved in the development of a number of other vaccines. So I've seen some that are really quite successful. The measles vaccine, done well before my time, was something that is the epitome of a successful vaccine, 98% efficacy on 2 immunizations, one at 12 months, one at 4 to 6 years, and this is what you get. Are we going to get that with HIV? I don't think so, but I think we're going to be doing better than the 31%, somewhere along that spectrum. And the way to do that, I believe, is to do the same thing that we have been doing all along, which got us to the scientific advances that I spoke about in the earlier part of the talk that we need to implement. Because we have our definite challenge in front of us, we have the goals that are set, and the only way we're going to get there is, again, getting back to what I said in that article, was to follow the science, and I believe that we will get there. So once again, thank you very much for giving me the opportunity to present this lecture. Again, I sincerely apologize for not being there in person, but I wish you a very successful and enjoyable meeting. Thank you very much.